And we often add also seed nut butters or nut butters, and I put a star there that, of course, unless you've got a peanut allergy or a nut allergy, we would not avoid any of the nuts. We would start them at least from 6 months of age actively. So in this child, the mother found breastfeeding too stressful. She switched to formula only, and this child then had 550 milliliters per day of energy dense formula without any force feeding. You could see that we've had initial catch-up weight gain, so you can see it was 4 to 5 grams per kilogram per day. And it took some time for feeding practice to improve. So this was 1 month. And then as feeding practice improved, as the stress improved, the velocity, as you can see, increased here to around 7 to 8 grams per kilogram per day. And you'll often find that initially your catch-up can be slow, especially if they're feeding difficulties. Now, this is where we change to an energy dense formula. And what is also important is here, we started here before the child was back on the 50th centile to already start chaining to a standard infant formula. Let me explain to you why. What we don't want is to then continue on an energy dense formula and this child goes above the 50th centile where they were before, and you actually start having a child that is overweight for their height or for their length. Because of course, as I already highlighted before, excessive catch-up can also lead to a predisposition for obesity, cardiovascular disease in later life. The Early Nutrition Project has got lots of information on that. That's led by Bertolt Koletzko and, of course, also Olivier Goulet from France. So monitoring catch-up is really absolutely critical. So you need to think, when you've got your child, how badly is this child growth faltering, and then decide how frequently you're going to see the child. This is a really nice chart. Also, it's published by Golden, where you kind of go, okay, this is where the child lies. For example, this child was between -2 to -3 standard deviations. I was around the 3 to 5 grams per kilogram per day of catch-up. So it will take 20 to 30 days for you to start to see the catch-up on the chart. So I would see this child in a month's time. So it is all very important that you do monitor growth and that you really do not let this child become overweight as a result of providing excessive amount of nutritional support. Then, of course, with catch-up, it's extremely important to measure them appropriately. There's also a chart that's from 1999, but it's still very valid to say, okay, what is the minimum interval of measurements? Because whilst you see that in weight, you do not see height or length catch up that fast. So this is a chart to kind of say, okay, for example, a 1.5-year-old, it's not worth measuring the length before 1.5 months, for example. And then on top of that, of course, you need to measure the growth, the length correctly, using the WHO technique of a supine meter, not just a tape measure, not a roller meter, because you cannot establish catch-up growth unless it's done in the right way. We've worked together with Nutrition and have produced also during a pandemic how to do this at home measurement. I've been practicing and doing home consultations, video consultations for the last 20 months, and I can tell you it's worked really well. To educate the parents, we've produced videos of how to do it at home, and in some cases I've actually found better and more accurate measurements by parents doing it at home on a flat floor against a wall with 2 parents. So this is also really useful. So you need to be thinking about the lessons to be learned. There are triggers for feeding difficulties. You can divide them into size, transition, organic disease, mechanistic feeding, and post-traumatic event. In this case, the weight dropping led to compensatory feeding. In this case, possibly there was a problem that it was too early with too much force. of giving solid food, so the transitioning from the breast and bottle to solid was most probably too fast, too forceful. And then there was the traumatic event of having the bronchiolitis and a nasogastric tube. So those can be triggered to lead to feeding difficulties as well. So what did we learn from this case? It's important to reduce triggers for stress and anxiety in non-illness driven feeding difficulties. Anxiety leads to wanting to feed more. Energy dense formulas allows to achieve target nutritional requirements with better energy protein ratios, and often it helps support breastfeeding because it takes the pressure off parents. It's important to also provide advice on solid foods and increase the energy density. Monitor the child's weight gain and velocity of growth. Advise also in a timely way when to switch from a fortification of an energy dense feed to a standard feed, and support this transitioning. So let's, for the last 5 minutes, move to an illness-related faltering growth. This is a baby boy born at 37 weeks gestation via planned C-section. He's got the diagnosis of a tetralogy of Fallot, so TOF, an open heart surgery at 3 days of age, and he had persisted with a large VSD and overriding aorta. Further surgery was planned at 8 months, but as you know, to do that surgery, the child needs to achieve specific weight gain. So initially, an NG tube was given, and this child was bottle fed with breast milk only, which he tolerated. And mom found it very stressful to continue to express breast milk and to provide nasogastric top-ups of standard infant formula. So this child was at the end just switched onto a nasogastric feed, but we did motivate the mother to try to continue some breastfeeding just for, comfort. So they found that as the child's requirements needed to go up, it was too much for the volume of just a standard infant formula. As you know, with cardiovascular diseases, you do not want to give too much volume as well. So there was this concern, the child needed to grow, you've got less volume than normal, and a standard infant formula did not provide sufficient energy density. This is a wonderful graph that Luis Marino has provided in terms of the congenital heart disease to think, what do you need to be thinking about? You need to be thinking about pre-operatively a long time beforehand. You need to be thinking about how are you going to get this child to have the right growth before they actually have their surgery. Then you need to be thinking about just peri-operatively and work towards reducing PICU length of stay, and then thinking about after the surgery, how do you avoid further sequelae as a result of the surgery? Now, in this chart, you can see weight started faltering. I've drawn the line, so this child was only born on the 25th centile, but if you look at the birth weight and you looked at where they dropped to, and I've converted that to Z-scores, it's gone to minus 2.3 Z-score, and you've got a faltering growth here. In fact, if you look at the Z-score here, it's also, this child is malnourished. This child was managing maximum 400 milliliters per kilogram, so 90 milliliters per kilogram from the formula in addition to breast milk. Mom was spending more time and they were getting more and more anxious. At that stage, healthcare professionals suggested the concentration of the feed. So they suggested, let's add to the standard infant formula an extra scoop. So in 100 milliliters of water, add 4 scoops of infant formula. But the weight gain velocity did not increase in this child. In fact, the child started vomiting more as a result of this intervention. Then the healthcare professionals suggested give more fat and more carbohydrates in a powder, add this to the feed, but this also did not lead to any catch-up growth. Now let's just remind ourselves, this is an illness-related faltering growth. This child has got cardiovascular disease, and this child has got increased losses now with more vomiting, increased energy expenditure. As you know, with cardiovascular disease, we see that, possibly altered nutrient utilization as well, and that is leading to this poor growth. So what did we do? We first of all advised mom to say, we took some pressure off, saying, support breastfeeding, whatever you can do, don't stress about it. We switched to an energy-dense formula, and in this case advised a slow switch because there was vomiting. We just wanted to make sure that this child was tolerating it well. And then after 1 week, this child was totally switched over, 400 milliliters of energy-dense feeds. So now doing 80 kilocalories per kilogram, 10.4 grams of protein. So now 2 grams per kilogram of protein, and start on vitamin and mineral supplements. And we gave also advice on solid foods and the energy density of solid foods. What you can see is, although this child was not achieving the WHO 105, 125 kilocalories, you can start seeing that this child was starting, this is where we started, to catch up in a slow way with the same volume of feed they were having, was more comfortable, the anxiety improved, and we also managed to get some solid food into the child. This data is supported by the many publications, in particular recruiting children with post-cardiac disease, with weight improvement post-surgery. Here you can see it's not the first during PICU stay, but post starting, and you can see really nice catch-up growth and also good tolerance of the energy-dense feeds. So what is the lesson here to be learned with this case? The energy protein ratio is disturbed if you start adding just carbohydrates and fats. So it can go down as low as 6%. And so we know optimal catch-up does not grow. In addition, if you increase the concentration, so by adding extra scoops of feed powder, you increase the renal solid load, so you increase the risk of dehydration. You can increase, as a result of that, the osmolality, which can lead to diarrhea and vomiting. In this case, it led to vomiting because it leads to delayed gastric emptying. And then, of course, it can affect the taste, it can affect the accuracy as well. This is a study, so these are hydrolyzed and amino acid feeds, but just wanted to show you, if you added an extra scoop of formula, you would go well above 400 milliosmoles, which of course is then hyperosmol. So what is the conclusion? Falttering growth should be managed using an individualized approach. We do have guidelines that have been published, but you need to think with that individual, is this achievable? And can you do it with that child? What is the underlying diagnosis? And would that work? Think not only about now, but about the future with your nutritional advice. So avoid excessive weight gain, therefore you need to monitor and ensure that the feeding advice also avoids feeding difficulties in later life. The modulation of feeds can impact on the characteristics of protein energy ratio, so we really dissuade people for adding extra scoops of feeds and modulating with just fat or carbohydrates. Think about your type 1 and type 2 nutrients, so vitamins and minerals. And ideally, of course, you want to get your multidisciplinary team to be involved. Thank you very much for listening. I'm looking forward now to your questions.
Thanks a lot, Doctor, for this talk. So we have some questions here. First one, at what stage we should promote catch-up growth and when should we stop?
An excellent question. Thank you for that. So you may recall that in my presentation, I had the three graphs: in the green, where you just have a dip, and an orange, where there's just plateauing but not crossing of 2 centiles, and then the red. So my opinion, it's ideal not to just do nothing when an infant starts crossing. So for me, I would intervene when a child starts already crossing 1 centile and not wait until they cross 2 centiles. So for me, I would say intervene as early as possible. You need to use your own, of course, clinical judgment in which way you intervene. Sometimes it does not need to be an energy dense feeds. It could just be technique of breastfeeding, expressing breast milk, topping up, or it could just be fortifying of food. But I would not wait until a child is faltering growth. If I see a child is dropping down, I'd start intervening.
Thank you. The second one is, what is the nutritional guidelines for catch-up growth of preterm infants after hospital discharge?
Gosh, it's a tricky question because, of course, as I already presented, the data at the moment is the strongest on intrauterine growth retardation and preterms, that we do not have too fast catch-up growth. So what I would say to you is, in terms of the guidelines at the moment, we have guidelines in terms of energy, we've got guidelines in terms of protein, all of that. But irrespective of that, is you look at where a child started in terms of their growth, in terms of their centile lines, where they drop to, and you slowly start working your way towards where this child started off. Now, the argument here is, what if a child did have intrauterine growth retardation? So what if a child was already born on -2, -3 standard deviation or Z scores? What do you aim for? And I think for that, at the moment, most of the researchers is saying you don't want to aim to make them fat, because that would really lead to later life consequences. So most of the research actually says, just make sure that they're tracking. If you manage to get them gain a little bit of weight, but I think trying to catch up the intrauterine growth retardation at the moment, the data is not conclusive from that perspective, and where to head for without causing obesity in later life. So I think that one is a very tricky question, and I think we are certainly very careful if a child's got intrauterine growth retardation, born preterm, also very low birth weight, then we'd be very careful with just pushing the weight up too fast.
Okay, so what are the current recommendations or energy protein requirements for catch-up growth?
So I've presented those, the ones that are mostly used are the World Health Organization, FAO. They're already from 2007, but they've not been updated because the guidelines still remain absolutely in place. What I just want to say, though, is those guidelines are general guidelines, okay? And they primarily cover children below the age of 1. So you would not be aiming for 120, 130 kilocalories for a child that is 3 or 4 years of age. So therefore, primarily for infants. So whilst we use those as a baseline, in particular to the protein energy ratio, all of us work in different domains. I gave you an example, for example, today of congenital heart disease. There are separate guidelines for catch-up for congenital heart disease, for traumatic brain injury, those. So what I always say is that whilst the World Health Organization are your overarching guidelines, don't forget that you may deal with specific conditions where there are publications on those. So I think the most important message for today is that you want your protein energy ratio. And that needs to be right. That is across the board, whether you're dealing with critically ill children with congenital heart disease, with neurodevelopmental delay, you want to have optimal protein energy ratio. And then you need to think, what does the research say? Does this child fit into the WHO guidelines, or are there specific guidelines in terms of energy protein for, as you've mentioned before, preterm energy protein for congenital heart disease or for other conditions?
Okay. How do you interpret growth faltering?
So the correction of growth faltering, as mentioned before, is really by providing nutrition in the optimal protein energy ratio, in addition to the micronutrients, vitamins and minerals, so that you have catch up at a 70% lean muscle mass and to 30% fat mass. So that is the way to catch up. And the way to catch up, though, depends also on the underlying diagnosis, as I already said, and your vitamins, minerals, your deficiencies that child might have, and also the severity. You may recall I've shown you a graph of how to monitor and how to think how quickly catch-up will occur depending on your rate of catch-up, whether that's 3 to 5 grams per kilogram per day, 5 to 10 grams. You can calculate more or less the rate of catch-up and therefore also decide on monitoring.
Right. How do you manage faltering growth in breastfed infants?
An excellent question. So as you saw today, we all need to support breastfeeding. There was a fantastic systematic review, I did not have time to present it, from last year that looked at promoting catch-up growth in breastfed children below the age of 6 months and how to achieve it. That systematic review found that in 2 studies there was good catch-up with cup feeding, but the practicality of top-up cup feeding was questioned because it's only really in the first month or 2 that parents can maintain the cup feeding. That systematic review has also shown that the addition of breast milk fortifiers showed some good catch-up and also top-up of feeds. Now, the top-up of infant formula and starting any infant formula, of course, goes against what the World Health Organization says in terms of exclusive breastfeeding. I think here, though, for us as healthcare professionals, the first objective we have is not to do any harm. So once you've looked at whether the technique of breastfeeding is optimal, whether the frequency of breastfeeding, the child is getting optimal hind milk, and also mom has got a sufficient breastfeeding milk supply. Once that has been exhausted, but the child is still faltering in growth, you as a healthcare professional need to ask yourself, is continuing just like this going to be harmful for the child, yes or no? And I think if the answer is going to be yes, if a child continues to falter growth, that's going to be harmful, then I would rather say I'm going to start just to give a small amount of energy-dense infant formula just to top up so that they can catch up, so that they've got enough energy to continue breastfeeding. A lot of times, just by getting their weight up again, having the more energy to suck from the breast and maintaining that, just by doing that, you actually protect breastfeeding more. So for me, it's not that providing an energy dense feed is stopping breastfeeding. For me, actually, it's seen as supporting of breastfeeding. But yes, we always want to exhaust as far as possible any support we can give to our breastfeeding mothers.
Okay, so what action do you take in case of faltering growth?
In the case of a child that is breastfed, I'm assuming. So okay. I'm assuming that is in the case of a child that's breastfed. So I would say if a child is below 6 months, then I would start off by looking at breastfeeding techniques, getting breast milk, my breastfeeding specialist involved to make sure that we've got sufficient intervals between breastfeeds. We're looking at expressing breastfeeds, starting with top-up of a cup, thinking about a breast milk fortifier if required. For us, breast milk fortifiers is not something we prescribe in the community. It's normally in hospitalized patients. And we monitor the child then, and if the catch-up does not occur how we want it, then as a second step, I would then look at an energy-dense formula. In children above the age of 6 months that are breastfed, I would first, outside of thinking about how the breastfeeding technique occurs, I'd be looking at fortifying the foods. I'd be looking at mom expressing breast milk, adding to the solid foods. I'd be looking at adding extra protein and extra energy. So in the baby above the age of 6 months that is breastfed, that has got faltering growth, food provides us with more options. But in both, as you can hear from what I'm saying, the first priority is the breastfeeding technique optimal? Is the frequency optimal? Does mom have sufficient breast milk, and can we use that first? Thank you everybody for having me, and thank you again, Dr. Sana, for arranging this wonderful Congress. I am really looking forward to the time when I can meet you all again in person. Thank you again very much, and hope you all have a very fruitful and educational day.
Thank you. الحقيقة أحب أقول كل سنة وإحنا طيبين كلنا، والدكتورة سناء حبيبتنا مجمعانا كلنا، مؤتمرها الرائع العلمي اللي دايما بنستفيد منه، وبروفيسور فواز وبروفيسور وفاء، وطبعا اختي الحبيبه الغاليه استاذه الدكتوره مي نصار، واخي العزيز الغالي ايهاب خيري استاذ دكتور، بندعي له كلنا بالشفاء يرجع لنا بالسلامه، واختنا الاستاذه الدكتوره ياسمين جمال ربنا يطمنا عليها، الحمد لله هي بقت احسن، بس ان شاء الله يبقوا معانا المره الجايه باذن الله. والحقيقه انا سعدت جدا بالجلسه، وزملائي على المنصه منورين كلهم، ودايما مجمعانا يا دكتوره سناء في العلم، وكل سنه وانتم طيبين.